Welcome to AETCM, the emergency medicine channel. A 28-year-old female came to ER with complaints of hematuria associated with dysuria. On initial 10-second assessment, airway was patent. Patient was speaking in full sentences with breathing-wise respiratory rate of 18 with the BP of with the saturation of 100%. Circulation-wise, heart rate of 95 per minute with the BP of 120/80. Disability-wise, GCS was full. Exposure-wise, patient was afebrile with a GRBS of 90 mg per deciliter. Coming to adjuncts to primary survey, and since patient was complaining of dysuria along with hematuria, suspecting UTI, we went ahead with the CPC-CRP point of care and a VBG.
Why you want to do this?
Any obstructive uropathy suspect causing hematuria, causing creat increase.
Since our venous blood gas will show creatinine value, you can look for any features of renal failure. That is the reason.
Yes. CBC wise, total counts came 16,000 with hemoglobin of 11, platelet of 2,29,000, CRP of 1.2. VBG wise, creat was 1.1. No acid base abnormality as such. Coming to sample history, 28-year-old female came to ER with complaints of noticing hematuria in the morning while passing urine with severe dysuria. She had no history of any fever with chills, any lower abdominal pain, any burning micturition, any flank pain, any fever or any joint pain or any unaccustomed exercise or trauma.
Why you gave a history of fever with joint pains?
Some conditions, fever with joint pain can present as hematuria. Example, glomerulonephritis. Swelling.
Suspecting strep-induced glomerulonephritis.
Or any upper respiratory tract infection. Patient, no history as such. She is not on any regular medications, not allergic to any known medication. She has history of recurrent UTI in the past and a history of nephrolithiasis in the past, for which she just underwent medical management.
What else you need to ask? Young patients presenting with the hematuria. Painless hematuria. This is painless hematuria, right? Painless hematuria. You want to explain how the hematuria is, right? The color, whether clot is there or not, isn't it? So what are the different colors usually the patient can say?
Either it will be cola colored or it will be red or it can be pinkish also.
Okay, so red and pink basically means?
It is it is fresh blood.
Red
and pink usually will be?
Basically means fresh blood. While cola colored or rusty colored urine means it is methemoglobin presence. That is, it has already oxidized. Okay. So, fresh blood usually means it is not from kidneys, it is either from ureters or from bladder as such. Bleeding is from elsewhere. Usually from kidneys is where you get cola-colored hematuria or even rust-colored hematuria as such. Okay, so that's color. What else? Presence of clots. Usually in hematuria, you don't get clots. Why?
Fresh blood.
Because for clot formation to happen, you should have significant amount of blood volume mixed in urine. Usually hematuria is easily seen, even if 1 ml of blood is there in your urine, the entire urine will be reddish in color. That doesn't mean you are having massive hemorrhage, you are just having hematuria. That's why you don't get any hemorrhagic shock in hematuria patients. No one is losing that much blood. But if there is significant volume of blood mixing, blood will get, coagulation cascade will be initiated and clotting factors will be activated. So if clots are there, you should expect bleeding, significant bleeding, somewhere outside of kidneys as such. Most commonest areas are
glomerular,
bladder, then ureter. Okay. One of the causes that can cause significant hematuria with the clots is
any procedure.
Post procedure, correct. Post TURBT procedure patients can have. Post urethroscopy patients after ligations and all patient can have. What else? TB bladder, carcinoma bladder. Carcinoma bladder is also notorious because CA bladder patients will have increase in micturition, decreased voiding, dysuria, and hematuria. Classically, your features of UTI without fever. So, with and without. So, elderly patients, you may think that patient is having UTI without fever and may miss a CA history. Not very common as such, but you should keep it in mind. Okay, then.
Coming to the history, since patient was complaining of severe dysuria, we started the patient on IV fluids. One injection cyclopam was given and tap pyridium was given. Pyridium is basically one is phenazopyridine. Basically phenazopyridine, which is a dye which goes in the urinary tract and acts as an anesthetic as well as analgesic.
Correct. So what is the side effect of pyridium?
Color discoloration urine. Again produces
reddish discoloration of urine. So if you are treated a patient with UTI with pyridium and patient after 2 to 3 days comes and says that hematuria is there, don't suspect hematuria. Most probably it is discoloration due to pyridium. Okay. So if pyridium can cause reddish discoloration of urine, what other drugs can cause reddish discoloration of urine?
Rifampicin can cause.
Most common. In India, rifampicin should be kept in mind. TB is very common, right? What else?
Phenytoin can cause. Nitrofurantoin can cause.
All three medicines are very commonly used medicine. This is why we have to keep it in mind. Because patients can come and say, we are having hematuria. The most important factor of hematuria is, hematuria really doesn't mean there is a pathological complication every time. Most of the hematurias are benign in nature. Especially youngsters, they may get a hematuria just like that, and even if you evaluate, they may not get a reason for it. Because of that, you should always look for drug history, whether they have taken these drugs. If it is there, it will very well explain. What other non-pathological causes are there for hematuria?
One could be patient. If it is a female, she could be on her menstruation, which could be mixed with this.
Correct.
thing. Then other than it would be if
Especially
consumption.
in children.
Oh. Okay. And other than that, if patient has consumed any food which is especially beet, if patient has consumed beet.
Food coloring and beetroots.
Beetroots can be there.
So this is more common in children, especially if they haven't drank significant amount of water to dilute it out. You will see significant reddish urine, and your parents can get a bit anxious because child hematuria doesn't look good, right? So food coloring as well as beetroot. Beetroot is very common, but food coloring can also be there. So cakes, any history of recent ingestion of cakes or colored foods, you need to ask. Okay.
Myoglobinuria can also cause myoglobinuria or hemoglobinuria.
So that we can come, I think in investigation we will discuss that part. False positive things, right?
Then coming to investigations, we send for a urine routine as well as a urine culture, and we ask for a USG abdomen plus pelvis to rule out any obstructive.
Why did you send a urine culture here?
A patient has history of recurrent UTI in the past.
So basically you are suspecting UTI. Okay, so
UTI.
I know that you have done a UTI and you came back to know that it's a UTI, and then you send culture. But culture is not required as a part of workup. It's urine routine. Do you want to send urine routine for all cases? For example, this patient, this is a young patient, right? Think that she doesn't have any previous UTI history. What else? What other investigation can you do to rule out hematuria? Rule out, not rule it. Dipstick test. So that is very easy. Urine routine definitely has to go to lab and get the reports, right? It takes at least 1.5 hours. But dipstick can be done on the bedside. Good thing is, if dipstick is negative,
it is negative.
There is no hematuria. So it has a good negative predictive value. So you suspect hematuria. Like patient complains hematuria, you don't suspect hematuria. You do a dipstick is negative. You can tell the patient, you are fine. You don't have hematuria. Dipstick positive really doesn't mean patient has hematuria, but dipstick positive means you have to send for urine routine. Yes, correct. So urine routine has to be set. Fine.
And we also ask for USG abdomen plus pelvis to look for any obstructive uropathy.
What did the urine routine show?
Urine routine shows numerous pusses as well as numerous RBCs with nitrate positive, with bacteria 3+ as well as RBCs 3+.
Okay. What does it mean?
Patient is having UTA.
UTA. So the hematuria was secondary to a urinary
UTA.
tract infection. You have nitrite positivity, pus cells, bacteria.
Bacteria
So
positive.
definitely. But what if this patient urine routine didn't show any bacteria or pus cells, but was showing blood? Your dipstick was positive, your urine blood is written positive, but there is no RBC in microscopy. Like how much RBC should be there in microscopy?
3.
Yeah, more than 3. More than 3 to 4 is there. You can say it is hematuria. It is better to repeat a urine routine, but that is mainly for OPD management. Doesn't come in emergency. But in emergency, more than 3 to 4 RBCs in males or females is pathological. Means requires evaluation. Fine. So you get blood positive but no RBCs. What does it mean?
Could be post-menstruation.
No RBC,
No RBCs.
but blood positive.
Could be myoglobin or hemoglobin.
That's a fast positive that we told. So the urine reports that you get has dipstick matrix in them and microscopy in them. So you need to understand dipsticks basically react to agents. So if free hemoglobin is there or myoglobin is there, to that globin it will react and show that blood is positive. But it's not blood. Okay, so if you get, that's why we told the dipstick if positive, you need to do a microscopy to see RBCs. If you don't see RBCs, it is a false positive test. For example, myoglobinuria, right? Okay, what is one of the most common causes of myoglobinuria?
Rhabdomyolysis. Most common?
Rhabdomyolysis is one extreme, right?
Okay.
Common. Protein injection. Protein injection. What else? Exertion, severe exercise, severe exertion. Severe exercise itself can cause some amount of hematuria, isn't it?
Yes, exercise induced.
So exercise induced hematuria is another thing. So in that you will get blood positive in dipstick and you will get some RBCs. But when you rule out all other conditions, nothing else will be there, just strenuous exercise. But similarly, severe exercise with dehydration can cause myoglobinuria, which can cause dipstick to be positive, microscopy to be negative. Sure. Then what else?
So USG was normal for this patient. So basically, we diagnosed her.
Why did you do a USG for this patient?
We did because to rule out any obstructive uropathy causing hematuria, because she was having severe dysuria. So
what is this right? But it's not obstructive uropathy causing hematuria, right?
Any nephrolithiasis or any.
You wanted to rule out
nephrolithiasis.
Nephrolithiasis causes hematuria and it causes obstructive uropathy. So nephrolithiasis.
So
when will you suspect nephrolithiasis? For example, this patient, did you really suspect nephrolithiasis?
If decrease in intake of water history is there, if patient has previous history of nephrolithiasis.
What is the history? What is the classical history a patient gives for nephrolithiasis?
Pain, loin,
classically is low into growing intermittent colicky abdominal pain. But the radiation of pain depends on the site of calculi. So patient may not have a complete low into growing, but if you have a colicky abdominal pain with one-sided colicky abdominal pain with hematuria, you should suspect UTI as well as nephrolithiasis. Fine. Since this patient has previous history, you suspected.
Showing calcium oxalate presence.
Correct. So urine routine will show
Calcium
cast.
oxalate,
Calcium oxalate cast will be there. Okay. Okay. So you did a ultrasound. Ultrasound didn't show anything. Okay.
So treating as UTI, we consider it as UTI.
So your
hematuria secondary to
diagnosis
UTI.
UTI. Okay. Now let's come to approach to hematuria. How will you approach a patient coming with hematuria to ER? So initially we told, basically it's to identify microscopic versus macroscopic. Macroscopic patient is going to tell you, I have reddish urine, pinkish, reddish or cola-colored urine. What to do?
So
Directly go for
urine,
dipstick.
Dipstick
Directly go for dipstick. Check whether dipstick is positive or negative. If it is negative, tell the patient, most probably it is false positive, most probably it is food coloring or what we told,
Any
drug
drugs.
induced or any other beetroot induced, all these things you rule it out. But dipstick become positive, take for
microscopic examination.
Microscopy, you need to see RBCs. If you see RBCs and there are clots,
yes, then we have to ask the patient, like evaluate the patient if patient is any urinary due to clots, if it's obstruction and went into urinary retention, or if patient is having any abdominal pain, or patient is having severe hemorrhage, causing the patient to have tachycardia, hypotension. So if these conditions are there,
or chronic heart failure features. If it is a chronic hematuria, chronic heart failure features.
If such complaints are there along with visible clots,
hematuria with anticoagulants.
If patient already
perfuse hematuria with anticoagulation, you should refer the patient to
emergency
department. So basically, once you do urine microscopy and the urine microscopy becomes positive, you are looking at whether clots is present or not. If your clots, you are presenting, you have clots, you are basically suspecting bleeding from anywhere else other than usually kidneys. So then the question is whether the patient requires emergency management or not. Emergency management is what you told. That is lower urinary obstructive features. So patient should either have difficulty straining of urine, difficulty in passage of urine, or anuria due to retention. If these are there, patient requires a temporary catheterization or even a Foley's catheterization to remove the obstruction. Similarly, if you are putting Foley's catheterization, it's better to give a bladder wash to remove all the clots so that further episodes will not happen. That's the first and foremost. Second thing is, this patient is having ongoing profuse hemorrhage with anticoagulation. So you want to see whether anticoagulation needs reversal or not. Because of that, you
profile has to be set.
Or patient is having hematuria with one-sided colic abdominal pain. Because of that, you are suspecting now ureteric calculi. So you want to rule out obstructive uropathy, and you want to see the size to see whether you require the patient for intervention or not. Then the last criteria is patient is having chronic hematuria and patient is presenting with the features of anemia or anemia-induced cardiac failure or tachycardia. Then you are saying that patient requires anemic correction, so we are referring the patient. These are the main indications for an emergency referral for patient. But patients will come with all the complaints. The question is how to further evaluate it. At this point, you can tell the patient that if these things are not there, there is no emergency thing, you can actually refer the patient to a nephrology OPD if glomerular bleeding, or urology OPD if non-glomerular bleeding. Fine, then.
If a patient is referred to emergency department with such complaints, one of them is like we'll have to relieve the obstruction.
No, we already discussed
that much is there. Then if patient doesn't have any visible clots, but hematuria is present microscopically, along with that, if patient is complaining of pain, acute onset of flank pain, then there are two ways. One, we have to go for imaging to look for any obstructive uropathy. You can go for USG initially to look for any hydronephrosis, followed by a CT, or we can go ahead with the CTQB directly. And other than that, if there is CTQB is normal, then suspecting it to be UTI causing pain, then we'll have to go with a urine culture. We'll send for the urine culture. If urine culture is positive, treat as UTI, ask the patient to come back in 6 weeks with a repeat urinary. If there is no onset of pain, hematuria is there, but there is no pain as such, painless hematuria, then we have to see the following criteria. One of the things is we have to ask for any history of any insect bite or any snake bite.
In India, snake bite is very common. Viper bite, isn't it?
Then other than that, we have to see whether if patient is having any albuminuria in urine, any increase in creatinine, any increase in hypertension or pedal edema worsening for the patient, or any RBC cast or dysmorphic RBC with anisocytosis and urine RE. If such features are present, then it is more likely to be a nephrological cause rather than a urological cause. Glomerular cause, basically. Yeah. So then patient has to be sent for further nephrological evaluation.
So what under? So in urine microscopy, if you get RBCs, you need to ask the person who did it to see whether they found any RBC
casts,
morphology
guns,
changes. Whatever morphology is fine, but any morphological changes is there or not. Then
You have to ask for any cast, RBC casts,
RBC cast.
albumin, albuminuria.
So proteinuria, that you will
proteinuria.
definitely get in dipstick test, whether it's 1 plus 2 plus, like that you will get. Then
Worsening of creatinine.
okay, renal failure. So whether this hematuria is associated with the renal function decrease or not.
Then worsening of hypertension or pedal edema.
So nephrotic symptoms or
Nephritic
nephritis symptoms are there or not. Okay, if these are there, you need nephrology evaluation. What are the most common conditions that can present with the glomerular hematuria?
One is post viral infection glomerulonephritis.
Post-infection
Any
glomerulonephritis.
post-streptococcal glomerulonephritis. Then it would be due to any acute intermittent porphyria if patient is having.
Okay.
Then
IgA nephropathy.
IgA nephropathy. Then
Alport syndrome.
membranous.
Okay. Basement membrane
Proliferative
disorder.
Then good pasture syndrome.
Okay. All this is fine. But glomerulonephritis and IgA nephropathy, we need to think because we can pick it up from history as such. Okay. Now, these are the most common things, right? Then it basically requires evaluation. There is no emergency management here. But one of the other conditions that you have to keep in mind in emergency department is any other condition that can present with hematuria. For example, young patients, especially females, presenting with artery-sensorium abdominal pain, hematuria, can be
Porphyria.
acute intermittent porphyria. Similarly, females, especially females, doesn't matter the age, presents with multiple reddish rashes associated with hematuria.
SLE.
HSV.
sorry.
HSV, but correct, SLE, or it can be vasculitis secondary to SLE also. So these conditions you should think about. Another thing is in India, snake bite you have to think about. But no snake bite person is going to come and tell you that I am having hematuria. But what you need to take care is, patients may have delayed reaction to snake venom. It doesn't mean that all snake bite will produce envenomation symptoms within 6 to 8 hours. Patient may not even remember that he got a bite. Patients can be waking up in the morning, by afternoon developing hematuria, coming for hematuria. They might have got a snake bite while they were sleeping. So it's prudent in India to look for any other features of envenomation. That should be looked into. Especially you have to set coagulation patterns. If you get very unnatural coagulation factors which cannot be explained, this thing. What else?
Other than that, red flags for malignancy, like any patient presenting with hematuria, do we need to consider the patient can be having a malignancy or that? There are some red flags for that. In case of female with age more than 50 years, in case of males with age more than 40 years. In case of
More
smoking,
chance in males.
more chance in males.
Males more than 45 years, females 50, 55 years, and then?
And other than that, occupational exposure to chemicals or dyes, especially benzenes and aromatic amines. Then if patient is having gross hematuria and irritative voiding symptoms, then chronic UTI with then history of pelvic irradiation or chemo with the drug cyclophosphamide. Then other than that,
so radiation to the pelvis
radiation
and
to the pelvis.
chemotherapy.
Chemotherapy, and then any family history of urothelial carcinoma.
Okay.
That much. And again, in painless hematuria, one thing to be considered in males is BPH. We have to rule out BPH.
BPH classically doesn't produce hematuria. There is no pathology to explain hematuria. The idea is, since BPH is occurring, there may be some neovascularization that causes friable blood vessels which can cause hematuria. But there is no textbook that says that BPH will cause hematuria or hematuria is caused by BPH. But that is one of the commonest finding that we get. The problem, as we told, hematuria most of the time there is no reason. And when you finally rule everything out, something that left will be BPH. Okay. Young male, 20, 25-year-old, presenting to you with acute onset hematuria, fresh blood, lot of clots. Okay. Patient doesn't have any, as I told, edema. Patient doesn't have any edema, hypertension. There is no low to growing pain. There is no UTI symptoms. No other rare causes for hematuria as such. What else will you think? Or what else will you look into?
Sudden onset clots.
Patient is having pain on the lower back or up.
Abdominal aortic aneurysm.
It doesn't, abdominal aortic aneurysm doesn't matter the age, right?
Oh, yes.
Abdominal aortic aneurysm is there. As you told, abdominal aortic aneurysm can have erodation into the renal artery, causing renal artery thrombus, can have direct hemorrhage into the kidneys as such. But that is non-age dependent. This is mostly young males. Trauma.
Oh, Tom.
Trauma, direct trauma. So if they are fighting or they had a boxing match and a direct hit to the kidney area, like our renal angle, right, can cause hematuria as such. Anything else?
Some serious conditions which can present to ER with hematuria could be either malignant hypertension, any
correct, malignant hypertension,
and any embolic renal infarction, then any renal vein thrombosis, any eroding abdominal aortic aneurysm, snake bite.
That's it, right?
Yeah.
So basically, diagnostic evaluation as such, very rarely hematuria will present as a emergency, and the most common emergency is urinary retention. That's it. Okay.